We now have the final talk of the session by Ramesh Daggubati. He's going to talk about IVUS and acute coronary syndromes.
Thank you very much, Gary. Great pleasure being with all of you today, and I'm really humbled to be presenting in front of all of you. So let me just intravascular ultrasound in acute coronary syndromes. I have no disclosures. I'll just start off with a quick case where imaging has been used, not particularly IVUS. This is a patient with ST elevations. I was called to take care of the acute MI in the midst of an EP procedure. You can see all the ablation catheters. And obviously, without imaging, we could have gone and put a stent in, or balloon and thrombolytics, or all the other medical therapies. So what the eye doesn't see and the mind doesn't know, it doesn't exist. I don't think that's really true. So you have to make sure that your eye can see first. And in this patient, from my prior experience, I kind of suspected what it is. So we went with the GR4, gave nitroglycerin. The vessel did not open up. So put a BMW wire, gentle balloon dilatation with the 2x12 at 4 atmospheres, and then did an OCT. And actually, OCT here showed there was no plaque at all. And so, I just wanted to quickly show that. So obviously, compared to histology and OCT, IVUS, because of grayscale, we always feel that maybe it's not as great. But now with the new high definition IVUS, as was shown by Gary, now you can identify all the 3 layers of intima, media, and adventitia even with the intravascular ultrasound. So this patient had obviously resistant spasm, and there was no need for any stent in this patient. So in acute coronary syndromes, and what are the cause of coronary thrombosis? Majority of it is due to plaque rupture and or plaque erosion. So rupture occurs in about 60 to 70% of the patients. Erosion is now being detected more commonly, especially in India, where people with the age of 25 and younger present with acute MI, they are having plaque erosions, and obviously some other reasons are calcified nodules. So detecting vulnerable plaques is of great interest for most of us. And on grayscale IVUS, you can have some criteria, whether it is plaque volume, plaque burden, and thin cap fibrinomas. All of them could be detected. And the virtual histology or integrated backscatter can detect what is the lipid core and the spotty calcifications as well. On IVUS can also be signs of acute coronary syndromes. And obviously, I'm not going to be talking about OCT or NERS in this talk. So OCT might appear that it gives a better picture, but we also can easily identify thin cap fibroatheromas, and usually thin cap fibroatheromas are anything less than 65 microns, and the necrotic core, and the cap may be infiltrated by macrophages and lymphocytes, and obviously type 1 collagen. So an OCT, this is how a thin cap fibroatheroma might appear, where you can see that very clearly. But how does it appear on IVUS? We'll look at that. And obviously, there's several stages of plaque formation to rupture, and again repair. And so these are all defined as starry lesions, going from starry 1 to starry 6 lesions, and coming back to repair and maybe healing of the thrombus and plaque rupture that happens, and maybe resulting in a stabilization of the plaque. So Faith and Ozaki actually looked at these and acute coronary syndromes and the stable angina pectoris are the lesions that can how they look, and IVUS as well. So this is somewhat similar to what you were showing the first probably your TCT at current MedStar in those days, Washington Hospital Center, right, Gary? Very difficult to know where the plaque thin cap fibroatheroma is on IVUS. But early on, actually, there is a great data to show that detection of spotty calcification in intravascular ultrasound, as you can see in this picture, that actually has been associated with the higher incidence of acute myocardial infarction or unstable angina pectoris as compared to less incidence of spotty calcifications are detected in stable angina pectoris. So you can see, but plaque burden and virtual histology is of great help, giving us much more information on similar to OCT on the plaque burden and how much of a necrotic core is there actually. So this is what I think is much useful rather than just grayscale alone, but combination of IVUS with virtual histology gives us a very clear idea of where the lipid pool is, and similar to OCT here. And I think probably compared to OCT, in my opinion, I think for residents and fellows, they can actually detect with this color differentiation by virtual histology much more clearly where the plaque necrotic pool is. So great study by Gary and Stone and so Greg Stone and partners, and Akiko is the second author in this actually. So detection of plaque burden along with virtual histology, TICFA, minimal lumen area, all of them are important. And in this study, you can see the plaque burden MLA, more than 70% of the plaque burden, and TICFA or the highest prognostic factors for people with resulting in acute coronary syndrome. So TICFA plus plaque burden plus minimal lumen area less than 4, definitely they have a higher median 3 to 4 year MACE rates in these patients with lesions. So as we know, majority of the TICFAs are 54 to 84 microns, and as I mentioned that now with the high definition IVUS, you can clearly demarcate where the layers of the artery are, and similar to OCT here. So we have done a study in India that we have looked at impact of TICFAs on coronary flow in acute coronary syndromes. The more number of TICFAs are actually are associated with slower flow, but definitely even having a single TICFA that is associated with the slow flow. So not just having multiple TICFAs, but any single TICFA is associated with the slow flow in this first picture, as you can see. So plaque rupture and TICFA with the varying luminal stenosis. So you can actually see that the luminal stenosis can be assessed by IVUS very clearly. And as with the high definition and virtual histology, and also other features such as positive remodeling, we can identify the necrotic core in these patients which have caused intravascular ultrasound. Again, in Srinivas Reddy and myself, we looked at these people who actually had on intravascular ultrasound, positive remodeling is associated with much higher incidence of necrotic core in about 24% of the patients. And so you can see that another feature where you can detect on IVUS and see that it matters in acute coronary syndrome. So a few slides about new integrated backscatter intravascular ultrasound done by Ozaki in Japan, and looking at the Terumo system. We do not have that, and probably Gary can show some in the discussion part that he can talk about it. So how does this look in lipid core abutting the lumen can be detected by integrated backscatter, and saying that actually these people who have a higher LCAL high chances of having acute coronary syndrome is much higher in these patients. So similar as was shown with the OCT here, now with the intravascular ultrasound, you can clearly assess very clearly that where the lipid core is and the lipid pool is, and where the fibrous tissue is. So in take-home message, and intravascular ultrasound can recognize, as mentioned just earlier by Akiko, that plaque rupture, thrombus, positive remodeling, spotty calcium, and plaque burden and TICFAs can all be identified with the intravascular ultrasound, which is grayscale. Virtual histology and the integrated backscatter IVUS can recognize the lipid pools and the necrotic core, and I think in ACS they're of great value. So with that, I'll stop here and I'll be happy to take any questions. Thank you.
I think we're actually exactly on time, and we now
discussion,
have... Okay, fine. I don't like to hold up the cath lab if they're ready to do their cases.
Dr. Ramesh, thanks for an excellent talk. You highlighted even the usage of virtual histology in IVUS, especially in acute coronary syndrome type of situations. People use it regularly, the virtual histology. I thought it is hybrid a lot, but not much used.
No, it is actually very useful, and we do use regularly because it's just pressing a button. I don't
Okay.
think you really have to do a lot of technology-wise. It's just a push of a button. You can get the virtual histology.
Colors appear, but do they always correlate with the scenario clinical picture? Kirti is harding the net horizontally.
I know, but I think a prospect absorb. I think Gary or Akiko could comment on that. Nowadays, with the much more usage of virtual histology, is going to come back up. What do you think, Gary?
I think virtual histology is dead.
Yes.
Dead. Okay.
So I think it's even taken off. The new software from Boston it's off the shelf. Really.
Yeah. So Boston's
Yeah,
equivalent
Boston
was
does not have
never approved. No, actually, Boston had something that they were trying to develop to compete with Volcano's virtual histology. It never was approved in the U.S.
Right.
And as far as I know, the Volcano virtual histology software is effectively dead. It's actually, every time you develop a new transducer, you have to revalidate and it's been supplanted by so much easier technique. If you're just looking for lipid and necrotic core, something like near-infrared spectroscopy is so much easier and so much more reliable. It really takes a core lab to utilize VH, and even then you have to know how to filter out artifacts.
I think we also felt the same, but we don't use nowadays. Usage of IVUS is coming down slightly in our place compared to OCT. But whichever thing we are comfortable with, we heard from Gary before, and 80% of the times both are interchangeable. But maybe specific subsets like what Dr. Akiko mentioned was very optimal. Unless there is flow, you can't use OCT. So obviously acute MI and total occlusions and osteal lesions and CKD patients were the most ideal, which is covered well.